I was listening carefully because it's part of my job to think about what I just heard insofar as what he need to hear next. So what struck me right away was that Amy Berman talked about person-centered care. This is an intensely personal journey that she's having us join, and we intend and hope it'll be a very long journey. And the ride to Niagara can be exciting, to the falls, we know that. And then Peter just talked about reimbursement systems and risks and hospitals and networks and great big insurance companies. Peter did say the patient once, or maybe once and a half, he did talk about patient coinsurance. So what I'm going to ask our panel to do now is sort of bridge the gap. We just heard about perhaps tectonic changes in the healthcare delivery and finance system from Peter, but there was not much at that level that addressed the person-centered view that I think Amy first introduced. And so as we do this, I want to, as opposed to doing long bios and so forth, and we'll go from your left to right, is Manasi, at NCQA, tell us in just a sentence why it's part of your job to care about consumerism. Give it to us in a sentence.
Okay, I'm a health services researcher and an anthropologist, and I've been working in cancer quality measurement and patient-centered care, patient-centered medical home issues for the last 4 years. And so is that what you wanted?
So you're duly employed, at least in part, to address our issue. That's what I wanted to establish.
Yes.
Thank you. Good. Amy, we know why you're here on patient-centeredness. Dennis Scanlon, what is it about your job that would possibly care about the role of the patient and the consumer in the healthcare system?
Right. Well, I think Amy sort of summed it up, everything that she said that's needed, the notion that outcomes are in part a good outcome as a function of patient preferences. I think that's something that the healthcare system is acknowledging more and more, but from a research perspective, we have a ways to go in terms of how we define quality measures to incorporate patient preferences, allowing for variation then across patients and outcomes, and all the drivers essentially of those outcomes. So I approach this from a research perspective and how we bring evidence to this and then structure incentives and organization and delivery based on the evidence.
Excellent. So it's your job to kind of take these qualitative observations and crank some data with those and then use the data to feedback and maybe change something. So Amy, after having heard what you said, I know you're listening to Peter Bach as well, and he was talking about great big system changes. Is there anything that Peter said that struck you one way or another insofar as it might affect patient-centered, on-the-ground, consumer-based decision-making based on what he said? How might this affect you, Amy?
I'm a big fan of Peter's. He's the voice of reality. But the fact is, he talked about rearranging the deck chairs. And it's time that we realize that we don't need as many chairs. There's some fundamental shifts that need to go on, and it includes, how we work with individuals to be able to structure the goals of care. That it is not simply a matter of looking at our billing and looking at our point of service, but that there are fundamental changes in what it is we're trying to accomplish. And that is really the opportunity for the greatest, not only transformation that's person-centered, but the best outcomes and value proposition in care.
But I don't want to let you go yet. When you heard Peter talk about shifts in site of care, outpatient to the hospital, you talk about hospital to home sometimes. When you think about those kind of mega trends, is that sort of pushing the patient around on a chessboard, or do you think that the patient will be regarded insofar as where the site of care is, what the co-payment might be? How does that hit you?
Yeah, well, we certainly are in an environment where there are greater costs that are going to be put back on the individual, on the consumer. And, in terms of point of service, I will suggest that there be a closer look in terms of the quality, the value proposition, not just the billing, but really looking at, where we can be most proactive. And the hospital is not really known for that. So, really the conversation that you heard was around reimbursement in a straight sense, but not really around care. And my question is, how does this really fit in terms of people cycling in and out of hospitals, which are really typically, even outpatient hospital care, typically poorly designed for continuity.
Okay, so now let's ask the research guy. So Dennis, what can you say about the magnitude or quality of the research base, the evidence base, on how to engage patients in this kind of care? What do we know about that evidence?
Yeah, well, I think it's very general, and I think that it's evolving, but I think we need a lot more work. And if you take a look at this area of oncology and cancer care, I mean, I think a lot of the points Amy brought up just sort of illustrate areas where we need research. I like to think of it as, what we're trying to do is kind of think about the way to redesign care delivery and incentives to promote good outcomes. And so if we take a look at what type of research is needed, a whole host of areas, like Amy mentioned, sort of helping patients understand their conditions, understanding and assessing risks and communicating those risks and treatment options, emotional and family support. So one of the things from experiences I've had is oftentimes when it comes to decision making, and it sounds like you had some good support with your mother, oftentimes there's battles between families around whether to go sort of in a more invasive or more intensive route versus the patient, what the patient preferences may be. Shared decision-making, the role of social support, how to adjust outcomes to account for patient preferences. So I guess my point is each of these areas are areas that I think are underdeveloped, areas where we need more research. And at the end of the day, we need to bring it all together to understand how do we redesign the care delivery system and provide financial and not financial incentives to redesign that. But I think the one point I want to raise is, in health services research, for years, we've documented variation in care, and oftentimes we assume that variation in care is bad. I think this is a situation where not all variation in care is bad. We have good variation and bad variation. Last night, the speaker talked about the use of genetic testing and ordering the wrong genetic test. That's bad variation in care. But Amy talked about today appropriate variation in care that would account for different preferences of patients related to sort of intensity and treatment decisions. And so that raises a level of complexity. How do we sort of adjust that outcome based on patient preferences and clinical evidence and sort of acknowledge that the outcome may vary depending on the not only the clinical situation, but the patient's preferences?
Great, good point then. So, Monsi, as a quality outfit, NCQA, is there some perceived or actual route from a patient set of needs to a research question data collection to setting up quality measures by which we can hold providers accountable? Is there a pathway there?
In the research that we've done on shared decision-making, and where we've heard from both clinicians and staff as well as patients, we have been looking at measures of potential measures of shared decision-making. Part of the problem is that data simply don't exist in EMRs, or in electronic health records, or in claims. Often, shared decision-making services are billed as patient education, or they're not billed at all, or they're under a nursing visit. When we've talked to several hospitals, sites, practices, data availability is a major problem, which makes the development of a quality measure extremely difficult because we can't find data in structured fields. So
Well, that's
one of the
really
problems.
encouraging. You can't even find the data. So
Yeah.
I'm just picturing this. So if Amy's people say we have a need, there's an unmet need insofar as meeting certain patient requirements or demands or preferences, and Scanlon starts working on it, probably gets a grant or two from various agencies. He's fighting for those all the time. He gets that money. He does the research, assuming he's got good metrics, feeds it back in the system. The system's supposed to respond at the shared decision-making point, and you're saying we can't capture or know whether or not it's being played out.
From the provider side, but from the patient side, one of the measures that we're looking into are patient-reported outcomes. And patient-reported outcomes, this is not just measures of satisfaction, which is what a lot of practices that do engage in shared decision-making will report. Well, they have higher patient satisfaction scores, but these are like HCAHPS or CAHPS types of scores that are not specific to the shared decision-making process. So the route to go is patient-reported outcomes on the experience of decision-making, of self-efficacy, confidence in decision. we're just now embarking on that path. And maybe Ethan would be able to talk about that a little bit more on, yeah.
So, Amy, in your experience, was anybody sort of taking data on your patient preference or your patient experience? Do you sense that data were being collected, whether in an EMR or a survey or anything else?
My oncologist, my original oncologist, did ask me what my goals of care were. She said, what is it that you're trying to achieve with your health? And I do know that she did write this in free text. She has an electronic medical record. And in Meaningful Use 3, under the Office of the National Coordinator for Health IT, they are looking at creating, this is such a basic concept, but it doesn't exist yet, creating a goal of care in the person's language within the electronic medical record. How do you know that you are actually trying to achieve, as a team, you have disparate members of the team, how do you know that you're trying to align care in the right way with what that individual is trying to achieve?
Was yours aligned in your direction? The first person told you, this is what we're going to do.
Well, that was the second person, but my original oncologist, yes, it was completely aligned. I went off to see the person specializing in inflammatory breast cancer. That person never asked me for a goal of care. And I should also say I'm a senior program officer at the John A. Hartford Foundation. The Hartford Foundation and the SCAN Foundation together have funded NCQA to develop the set of person-centered measures. So we will be helping to support some of that work internally. But there's a lot of work going on around the country, and it's not necessarily, we're at the infancy of all of this.
Okay. So Dennis, if we're at the infancy, how do you propose to fill in these gaps here, some of which you already highlighted?
Right. So, I mean, I think we need data from multiple sources, and we need to combine this in a way that has kind of, sort of research principles that allow us to sort of learn. So, for example, if we take patient outcomes, patient-reported outcomes, it's good to know those. But if we have those in isolation of what the treatment regimen was, that they're less informative. Okay, so suppose we combine that with the treatment regimen. What we also don't know is what kind of discussion occurred to get to that treatment regimen. And you can have all kinds of different variation. You can have a good outcome when the treatment regimen was maybe not the best. I mean, that can happen. You can have a good outcome when there really was no shared decision making. And then you can have a good outcome where sort of all those things happened. And so I think as I look at it, we need patient experience, patient outcome data. We need data on sort of what happened in the clinical setting and the trajectory over the episode or the clinical setting. But we also, and this is probably the most difficult to get, we need, and often not collected in detail in a lot of patient experience or patient outcome surveys, we need some detail about that interaction, about discussions about risk, about discussions about treatment options, whether patients feel that their views were considered, and also how care was organized and delivered. So I think that when you put all that together, those are difficult studies to do. And then, of course, you want to sort of overlay that on, we want to have external validity, we want to have sort of large enough sample sizes and such. Not, frankly, not simple research. What I worry about is, on the one hand, we want to encourage innovation in the organization and delivery of care so that we can get better outcomes and patient outcomes. But there's also a high incentive for marketing as well, right? I mean, so for organizations to market and say, we do this well, but what is the evidence? And so I think we're sort of got to, at some point in time, have evidence for patients and sort of, push away some of that less objective marketing information, but at the same time, not discourage innovation and allow people to market on where they're innovating.
Fair enough. Monsi, back to the shared decision-making realm. So we're trying to push toward the shared decision-making. How confident are you that shared decision-making, at least currently, accounts for different ability, comprehension, activation levels of patients? We're not all the same, and if you're trying to capture data and affect behavior change, how well does the system take account of different abilities of patients and their families, for that matter?
Well, first of all, there are very few sustained shared decision-making models in different organizations. Period. And we've just completed a project to highlight some of the case studies of of these practices that in hospitals that have engaged patients in shared decision making, and then we went and talked to the patients in focus groups. And most of these models are really based on providing evidence-based decision that explains decision aids that explains risks and benefits of different treatment choices, which is great, except that usually this is only based on one decision at a time. So say lumpectomy versus mastectomy, tamoxifen, yes or no, active surveillance or radiation or prostatectomy, say for prostate cancer. What we hear from patients is it's great to have the evidence-based decision aids and learn the risks and benefits. Most of them, like Amy, go off and do their own research as well. Not everyone does lit reviews. Most people Google it. And they don't always trust everything that they read. They know not to trust everything they read. They want information. Patients want information. But they also sometimes want advice. So there's sort of a tension between wanting to make your own decision and owning it, but also wanting some advice on, okay, so I've got these two options, but I really don't know what to do. And the other part of it is then wanting empathy from providers and the care team, and tools to be able to make a decision and have confidence in your decision. Because a lot of patients will make a decision and they may not regret it, but they're not sure if they made the right decision.
So, Dennis, Monty just rattled off a bunch of things that would be swell to have in shared decision making. Empathy was one, there's several. Are we anywhere near quantifying that?
I don't think so. I have, I guess a couple thoughts. I think the question I sort of puzzle with is sort of who owns this? Sort of who owns the responsibility for getting the information, and sort of the systems design the way that we're all talking about that perhaps we'd like to have. Is that the insurer? Is that the payer? Amy described an example where, based on her decisions, that was sort of financially beneficial to the payer. But we know patients don't trust payers. The notion here that hey, they're looking to save money, cut the bottom line, go the less invasive route. But is there a mechanism where payers can kind of coordinate this for patients, maybe through a third party or a contracted third party with credibility, to help patients get the information to make decisions? You might say, well, should this be on the provider side? Perhaps providers are more trusted, but the delivery system that we currently have, as we're describing, is not the delivery system that we want. So are providers willing to change, a la Peter's sort of example of what the incentives are, or is there some additional, nonprofit or third party? So what I sort of struggle with is, where is it in sort of the landscape that we can organize and arrange for this holistic information to give patients what they want, what they may need, help them make better decisions, but integrate that within the fact that we have, sort of those who pay for care and those who deliver care.
Okay. I have a closing question for you in the interest of time. We just want to have a brisk statement in response to this. And here's the deal. So among the many things that are changing are is the environment for financial risk to patients, right? Whether you could get on healthcare.gov and make choices or not, the drugs that Peter showed, that he has to shift to a logarithmic scale, there are co-payments and deductibles that have to accompany those. How would each of you propose to enhance the role of the informed patient/consumer in rocky economic conditions? Okay? So whether it's, again, federal health policy or changing delivery sites of care, the greater cost burden on patients, more people being pushed into bronze and maybe even eventually zinc plans, how do you enhance and inform consumerism from the economic side and not just the clinical side? Are we anywhere near there? And I'll ask you for an answer to that question in a sentence. Who's brave to go first?
I'm happy to go first on
We
this.
know you're brave. Okay, so Amy, what is it? On the economic side, consumerism.
You used a term, force consumerism.
Force or forced?
You said, how are we going to force consumerism? And I think that's the wrong question. Consumerism has arrived. Consumerism is here. And I think fundamentally, people are going to demand certain things. Researchers are going to tell you that we don't know enough yet. We certainly don't have methodology and measurement down yet. But here's what we do know. We need to be able to get a diagnosis. Pretty much you get that Prognosis, the likely course of the disease, they're entitled to that. Choices about the care, what it's going to feel like, what's the benefit now, what's the longer-term benefit, and cost. If you can do those 4 things, you will be able to give somebody a context, and I have to say, in all likelihood, that person's going to get better care, and you likely are going to win as well in the process, and you will be their hero.
So a 4-dimension sharing of information where the 4th is the economic part, right?
That's it.
But
And the
it can't
IOM
quite-
report has it as well.
But it's got to be integrated information, not just one dimension alone, correct?
That's correct. It comes in the form of palliative care. I would suggest you all fund palliative care teams to go hand in hand
Got
in
it.
care, but that would be my recommendation.
Monty, you got to go with this one?
Sure. Patients need navigation support and logistical support. In different places, different people provide those functions. It could be a nurse navigator, a patient navigator, care coordinator. There are various different people that can fulfill that role that can also provide that information on finances and navigating payer systems and reimbursement.
So bring a buddy.
Bring a buddy.
Bring a buddy that gets it. Dennis, how do you pull the econ side into this?
So I think the economics are interesting and challenging because when we talk about insurance enrollment, there's a lot of incentives, particularly for reasonably healthy people, to think about or potentially discount high deductible plans and such, and really think less perhaps about the future and uncertainty that the future may bring, where what they buy now may have strong implications for their care in the future, in terms of networks and who they can and cannot go to, treatment options, what may or may not be available, and ultimately the financial consequences of this. So if you're out there shopping now, price may matter in terms of premium. You want general coverage, and bronze, silver, or gold may not make a huge difference for certain types of care, access to care and such. But it's when you get into situations like Amy, you get into situations like I had with my son this summer on the need for some eye surgery, where that's when those consequences economically start to impact in terms of can you go to an academic medical center? Can you get a second opinion? Do you have access to maybe some of these not yet well-developed services that I think we need to develop, which will help patients with decisions?
Excellent. So it really is a multi-attribute decision, and to try to kind of tailor that to patients with different abilities is an extraordinary challenge. So thank you very much. So for Monty, for Amy, for Dennis Scanlon, please join me in thanking this great panel.